Good morning, everyone. I'm Dr. Jagan Mohan Reddy, surgical gastroenterologist. And at the outset, I would like to thank you, Vijay sir, for making me a part of this wonderful academic session. And it's a privilege and honor to speak in front of Dr. Palnivel sir, whom we always have an inspiration, and to speak in front of my teachers, Dr. Pratap Reddy sir and Dr. Birappa sir also. And I would like to start my topic on locally advanced gastric cancer. So here I am confining myself to staging and evaluation. Locally advanced gastric cancer is a disease where you have a gray area. Always surgeon will have an intention to operate first. But we should always learn, or as Dr. Vimlakar was telling, surgeon is not the only hero. We should always have a multimodality approach where we'll have in coordination with other consultants. And this is our team. So what is the first definition of locally advanced gastric cancer? Anything beyond muscularis propria, they come under locally advanced gastric cancer irrespective of the nodal status. So I'd like to tell only two things. I think TNM staging has been dealt already. Where we have T3 is subserosa, T4A is involving serosa, T4B is involving adjacent structures. And it always includes potentially resectable and borderline resectable. I would put it this way. What is borderline resectable? Borderline resectable is something where we have an intention of potentially operating it, but an uncertainty is there attaining R0 resection without neoadjuvant therapy. And this is a diagram where you can see where it involves beyond muscularis propria, it comes under locally advanced gastric cancer. Regarding this part, I have already dealt T4A and B, serosa, breaching, and involving the adjacent structures like pancreas, spleen, and colon. And regarding nodal things, the minimum number of lymph nodes for an adequate lymphadenectomy is 16. In D2, it is around 30. And this is an evaluation everyone practices. But here, I'm here to just put forward some guidelines based on NCCN, when to do and an appropriate timing. And these are the tools available in almost all hospitals nowadays: endoscopic ultrasound, CT scan, PET CT, and when to do PET CT. And emerging things are from biomolecular sequence, where it will help in chemotherapy, neoadjuvant and adjuvant scenarios. And staging laparoscopy and cytology is an important tool which has been added in the staging part of locally advanced gastric cancer. And coming to endoscopic ultrasound, it is very important for early gastric cancers, as it has been discussed. The only limitation I would like to tell in endoscopic ultrasound is T4B. Due to inflammation and all, it is inaccurate. Whenever an adjacent organ is involved, here a CT scan will always outscore over endoscopic ultrasound. Regarding end staging, it is as low as 30% sometimes, but an average sensitivity is around 60 to 90%. It is very sensitive for perigastric nodes, not for N3 and all. Here in endoscopic ultrasound, regarding nodal staging, the main purpose or something, it comes in the form of FNAC, where it will have a role in indeterminate lesions. As per the guidelines, endoscopic ultrasound is just an optional in potentially resectable non-metastatic cases. As I have told, it always have a therapeutic purpose, where we can have a cytology proof when you have a suspicious nodes. And it is always complementary to CT scan, PET CT, and staging laparoscopy. The limitation of ultrasound comes, as I have told you, in T4B diseases, and it is always an operator dependent. So whenever endoscopic ultrasound, one comments on whether it is between early or locally advanced, you should always have an experience how to differentiate it, and it is not a useful thing for metastatic disease.